Thanks a lot. It really is an honor to be here to speak to you. This is one of my favorite groups to speak to throughout the year. When the foundation called and asked if I would give this talk, they wanted a research update. And so I gladly accepted, and then they emailed back about a week later and said, can you spice up the title a little bit for us? So that's where I came up with test tubes and trials, updates on the research front. But that was really as easy as it got, because then when I started thinking about how to condense everything that was going on in the field of research, and endometrial and uterine cancer became quite a daunting task to kind of boil that down and then provide it for you in an interesting fashion over the next 30 minutes. So I've given it my best shot, so we will start with this whirlwind tour of a research update for uterine cancer. So this slide just shows a little bit of the breadth and scope of what we talk about when we think about medical research. Let's see, I think I have a laser pointer here, but way over on one side we have the basic research or basic science research, and this is things you may think of in terms of laboratory mice and test tubes and petri dishes, and this is where the hardcore science is going on. And then from that point we have the clinical research, which many of you may relate to in terms of clinical trials that are going on, testing various chemotherapeutic agents or testing different surgical techniques. A little bit further over we have epidemiologic research, and that's looking at big populations of patients to try and glean data from. And then we even have secondary research, which is essentially research on research, and I'll be alluding to some of that during this talk as well. So really a lot of information to condense into the time. So again, for this whirlwind tour, we'll start out looking first at at the state of the art in screening and prevention, early detection. Then we'll move into treatment and a little bit of how molecular profiling is really starting to change the landscape of treatment. And then we'll touch on a couple of issues, and I think the speaker after me, Dr. Modisett, will also touch on those: survivorship and then quality of care. And those are issues that we perhaps haven't paid as much attention to in the medical field as we should, and certainly getting more attention now. So this is a chart that you've all seen earlier today, and this is really the state of the art in the epidemiologic research for uterine cancer. But I won't go over these numbers again, other than to say that there are about 50,000 new cases of uterine cancer per year. It is the fourth most common cancer in women, and there is about a 1 in 38 or a 2.6% lifetime risk of developing uterine cancer. And again, as the speakers before me alluded to, there are a number of types of uterine cancer. There's the uterine cancer that develops in the wall or in the muscular layer of the uterus, and those are the sarcomas that constitute about 5% of uterine cancers. But the bulk of uterine cancers are the endometrial cancers that develop in the lining, and that's predominantly what the focus of my talk will be these endometrial cancers. This is a clinical overview. It's available in your chart, but for sake of time, I think this has been discussed by the prior two speakers as well, so I won't go into a lot of that, the clinical review for you. So for those of you that are survivors in the room, probably prior to the day of your diagnosis of endometrial cancer, endometrial cancer was probably not even a blip on your radar before then. It is certainly not something we screen for. We don't have good screening tests for it. And the discussions of prevention usually get short shrift in the busy doctor's visit, whether it's with your family practice provider or OBGYN. But I really like this quote by the Harvard biologist John Cairns. He says, "The death rates from malaria, cholera, typhus, tuberculosis, scurvy, pellagra, and other scourges of the past have dwindled in the U.S. because mankind has learned how to prevent these diseases. To put most of the effort into treatment is to deny all precedent." So this really highlights the importance of disease prevention, or at least early detection. Unfortunately, we don't have a good screening test for endometrial cancer at this time. And what do I mean by screening? Well, screening is taking a look at a group of of folks and trying to separate the well persons from those who have undiagnosed pathologic condition or who are at high risk of disease. That is, looking for a cancer before a person has any symptoms from the cancer. And common screening tests that you may be more familiar with are like the mammogram for breast cancer, certainly colonoscopy for colorectal cancer, or the Pap smear even for cervical cancer. But again, there are no good screening tests for uterine cancer. And what do I mean by good screening tests? Well, there are a number of criteria that go into making a good screening exam, and I won't read this slide verbatim to you, but these are the criteria that we look at to determine if a test is worthwhile to launch to the mass public to screen for disease. So there is no standard or routine screening test at this time, as I've said a couple of times now. And why is that? Well, there's a number of factors that go against screening for endometrial cancer with our current state-of-the-art that we have. One issue is that early symptoms, that vaginal bleeding in most cases, allow the detection of the disease when the progression of the disease can be stopped and cured. And that's the vast majority of the population that develops endometrial cancer are detected that way. So it's very, very difficult to show that a mass screening effort launched across the United Nation, for the cost that would entail, would provide any dent in actual survival from a disease that's largely cured in 80 to 90% of the population. But that's frustrating for the 5 to 10% of patients who the disease is not cured in. But currently, the other major issue is there are no test that's sensitive or specific enough and is acceptable to patients and physicians to launch as a mass screening effort. And those terms, sensitivity and specificity, are very specific statistical terms. It means their ability to prevent false negatives from occurring, so people that do have the disease that are told they don't have it, and from false positives occurring, that's telling people there is an abnormality when there really isn't one. And those are pretty stringent statistical criteria to look to when we're looking at a screening test. So there are some tests that may find endometrial cancer, and these have been studied to use as screening tests. Certainly the Pap test that most people are familiar with may detect some patients with endometrial cancer, but this is only abnormal in about 60 to 65% of endometrial cancer patients at best. So it has low sensitivity. That means it has a very high false negative rate. So a lot of people would be falsely reassured by an abnormal Pap smear if they thought it was really looking for endometrial cancer. So transvaginal ultrasounds have been looked at. Those are really good at telling us the thickness of the endometrial lining. And really, when you look at it in a postmenopausal population, the sensitivity of that test is okay. It's going to pick up most of your endometrial cancers. But the problem with it is its specificity. It has a very, very high false positive rate. It's going to pick up a lot of benign things like polyps, fibroids, just some normal thickening of the endometrium, so it's going to result in a lot of unnecessary endometrial biopsies, perhaps unnecessary surgeries, and a lot of anxiety in the population. So I mentioned endometrial biopsy. And what about that as a screening test? Well, it turns out endometrial biopsy is sensitive and specific. But for those of you in the room who have had an endometrial biopsy, it's not a very pleasant experience to go through. And it's not something that you're going to probably lure patients into the doctor's office for an annual endometrial biopsy if their risk of the disease is only 1 to 2% in the population. So you can see how, though sensitive and specific, this is not an acceptable screening tool for the general population. So screening tests have risks. They have the risks of finding the cancer but may not be able to improve health or survival. There's false negatives that can occur, which would falsely reassure people. False positives can occur, which would cause undue anxiety and further testing. And certainly the side effects may be caused by the test. That's discomfort, bleeding, infection, or rarely, in terms of the endometrial biopsy, a puncture of the uterus may occur. And there are some subgroups of patients who are at high risk. And when I say high risk, these are the very high risk patients where the population risk goes from about 2.5% up to about 40 to 60% lifetime risk of endometrial cancer. And in these patients, like the hereditary risk from Lynch and Cowden syndrome, to name the two most prevalent, it does make sense in this group to recommend a more aggressive screening policy, and we do, in fact, recommend annual endometrial biopsies in this very, very high-risk population. So certainly the be-all and end-all of screening and where we hope to go with this is the research into biomarkers that are going on right now. And biomarkers, simply stated, are substances or proteins or something in the body of people with precancerous conditions or cancerous conditions that aren't found in the healthy population. And ideally, the search for biomarkers can be done in easy-to-get-to places. Unlike the endometrial biopsy, we hope to find these biomarkers in the urine, in blood tests, or even potentially there's significant research going on into finding these biomarkers into cervical or vaginal fluids that could be collected right at the time of a routine Pap smear. There's much research going on in this field. We've not found the ideal biomarker yet, but there are certainly a number of suggested candidates that are being validated at this time. And one interesting test that I'll highlight is the Pap Gene Test by a group of researchers. I think this is led out of Johns Hopkins. But what they're doing with the Pap Gene Test is sort of exemplary of what we hope to accomplish. They have identified a number of a panel of gene mutations that are commonly mutated in endometrial, and incidentally also some mutations identified in ovarian cancer. And then they are doing a simple cytobrush Pap smear into the endocervical canal looking for sloughed off cancer cells or cellular fragments that they can collect, and then compare this panel of known mutations versus the DNA that they collect from this Pap smear-like test. And so this is very preliminary, but in their 24 patients that they had with endometrial cancer, they were able to correctly identify all of the patients. And so this is the hope of the direction that this biomarker screening is going. This is very, very preliminary and certainly needs the scrutiny of validation on much larger numbers. But these types of things are exciting and demonstrate the direction we're going with screening. So if we can't screen for endometrial cancer, uterine cancer at this point, we can make an impact in terms of prevention. And I won't spend too much time on this, but prevention is certainly actions taken to lower the chance of getting endometrial cancer, and this is based on knowledge of risk factors and protective factors. So you've heard a number of the risk factors already. Certainly most of these are related to lifetime estrogen exposure, and this may be increased by beginning your period at an early age or late menopause. Certainly obesity increases the total body estrogen and the total body estrogen that's seen throughout a lifetime. Tamoxifen was discussed by, I think, Dr. Barakat, and it's used for breast cancer, but it's also an estrogen-like compound that can increase risk. And certainly some of us are born with a genetic load that gives us a greatly increased risk of these cancers. So some of these risk factors are modifiable, some of them aren't, and then there are protective factors as well. Oral contraceptives with the progesterone in addition to the estrogen are very protective against endometrial and incidentally ovarian cancer, with an up to 50 to 60% risk protection from being on oral contraceptives for a period of years. I think 5 to 6 years is quoted in most studies, but any duration of oral contraceptive use seems to be protective. Also physical activity, pregnancy, breastfeeding, these are all conditions that tilt the balance in terms of progesterone, which is sort of that yin to the estrogen yang, if you will, that decreased lifetime exposure of estrogen or increased lifetime exposure to progesterone. So I highlight just a couple of trials out there that are looking at various forms of chemo prevention. That is taking a medicine that can prevent endometrial cancer. I've already mentioned oral contraceptives as perhaps a means of chemo prevention. The group out of MD Anderson, who's doing a great deal of research in the realm of uterine endometrial cancer, I have this trial open currently. It's a chemo prevention trial looking at the drug metformin, which is a drug that's been used for years in diabetes, alone or in addition to lifestyle intervention, that's diet and a coached exercise program. And they're looking at endpoints within the endometrium that would show a regression of those proliferative markers that we see in the endometrial hyperplasias, the precancers, and the cancers. And so this trial and other trials similar that I'll mention during the program are located and can often be found on clinicaltrials.gov. So and these trials change all the time, so I would advocate that you look at clinicaltrials.gov as a resource to find open clinical trials. So what about cancer prevention in these ultra-high risk patients? Well, the current standard is risk-reducing surgery. That's removal of the ovaries and uterus, and this significantly reduces the endometrial cancer risk in these patients. And it certainly seems to be a cost-effective, from a societal healthcare perspective, when cost-effectiveness modeling is done. But there's an unknown impact on survival. But this is only on the very high-risk group for endometrial cancer. But interestingly, they're also now looking prospectively at chemo prevention in these high-risk patients. And this is a study done by Karen Liu's group at MD Anderson that is randomizing patients, or that randomized patients to oral contraceptives, the birth control pills, versus Depo-Provera, which is an injectable progesterone. And in both groups, they saw markers or endpoints in the endometrium that were indicative of the changes that would be helpful or preventative against endometrial cancer or decreased proliferation within the endometrial cavity. So these are exciting things going on in the realm of cancer prevention that may be translatable down the line to the general population as well. So transitioning from screening, prevention, early detection, we'll talk a little bit about endometrial cancer treatment. Certainly the standard treatment at this point is removal of the uterus and ovaries, possibly with lymph node removal, possible with radiation therapy in some form or another. Chemotherapy has been mentioned as well, and then we'll talk a little bit about the special circumstances of fertility preservation and ovarian conservation. So the mainstay for years of endometrial cancer treatment has been hysterectomy with removal of the ovaries. But that has changed dramatically in the past decade in how we've accomplished that, with many centers now moving towards a minimally invasive approach to uterine cancer, endometrial cancer surgery. In fact, it's 1993 was the first year that that it was published that laparoscopy may be a reasonable approach to hysterectomy and staging of endometrial cancer patients. So over that 20 years, we've had an accumulation of data that have shown this minimally invasive approach may result in shorter hospitalizations, decreased blood loss, decreased long-term side effects from the surgery, and overall improvement in the quality of life of patients over open surgeries. But the lingering question that's been out there for over this past decade and a half, 2 decades, are we accomplishing the same cancer outcomes when we're doing these minimally invasive surgeries as we do when we do our traditional open surgery? And we have some reassurance in that from a paper that was published last year out of the Gynecologic Oncology Group, or the GOG, in the LAP2 trial. And briefly, what you're seeing here is that in the groups were randomized to either open surgery or laparoscopic surgery. And so the recurrence curves here and the survival curves between those two groups, probably from your vantage point, look like one line, because essentially these curves overlap. And this gave us really the first solid reassurance that we were achieving similar outcomes in minimally invasive surgery that we were able to achieve with the traditional open operative procedures. And that was good, because the editorialist for this paper in the Journal of Clinical Oncology said it aptly that the horse is already out of the barn with minimally invasive surgery in many centers. Most of us were doing this already for the appropriately selected patients. So this is reassuring to get this data. Now, there were some quirks about the statistics of the LAP2 trial that I won't dive too deep in that caused some to question the validity of the study, but we've since had additional data that has been analyzed, as well as this meta-analysis from the Cochrane group that have looked at all of the trials in minimally invasive approaches, and they again have found that blood loss is decreased, hospital stays are shorter, and cancer outcomes appear to be equivalent. So this is one of those groups that specialize on doing research on research, so it's good to see these corroborating data in addition to the LAP2 trial that came out. So what about robotic surgery? I see there's a robot that's wandered into the hallway out there as well. You may have passed that on your way. The robot has been proposed as a mechanism to, or an alternative to traditional open surgery or laparoscopic surgery, and it certainly has a number of pros and a few cons. And as an editorial, this is strictly my opinion, but I'll get it out there that I like the robot, and I think it is an appropriate tool for the carefully selected and appropriate case. So that's a big caveat there. But the pros certainly of the robotic platform of doing uterine cancer surgery are a very nice three-dimensional high-definition image that we're able to view. The range of motion of the robotic arms, and there's no better way than to show it when the instruments are in the abdomen. There's wristed tips to the instrument that gives us a much greater range of motion at the operative table rather than the traditional laparoscopic instruments, which just move in a couple of dimensions. There may be less skill needed to master the robotic surgeries, and it's certainly easier on the surgeon as we're sitting at a console rather than twisting and turning at the operative table for 5 to 6 hours or 3 to 4 hours, whatever the time frame may be. So there's a lot of benefits of the robotic platform for complex and complicated surgeries, and I would advocate that a lymph node dissection and many endometrial cancers are that complex of a surgery. But the cons are it is an expensive tool. It is the upkeep of the robot costs more in operative time, operative teams. Hospitals that have adopted the platform now very aggressively market it, and before they bought the platform, it was marketed very aggressively by the company. And so when you have something that's appearing on billboards that you see on the interstate rather than reading in medical journals, it makes everyone a little bit uncomfortable about the adoption of these new technologies. So again, I like the robot, but I like it in very specific cases of complex surgery, and I'll kind of leave my editorial at that point. So we heard a lot from, or a little bit from Dr. Barakat about lymph node dissections, and as I was writing this part of the talk, every new slide I started with, this is a very controversial subject. So I'm not going to say that before every slide, but this is a very controversial subject. The beliefs in this range from nobody needs a lymph node dissection to everybody needs a lymph node dissection from the bottom of the pelvis up to their tonsils. And there is not a lot of agreement in between there. We are trying to gather that data, but I don't know that it's forthcoming to make a definitive decision, so I'm not going to wade into that quagmire any further. Certainly the hope is we will identify biomarkers like I discussed earlier that will help us better identify the patients at risk for metastasis and help us tailor our surgeries to those patients. And certainly I like the sentinel node, the idea of sentinel node dissections that Dr. Barakat mentioned in his institution, and that of Dr. Vallejo, certainly the pioneering this less morbid approach to gathering the information from the lymph nodes we need without subjecting the patient to the long-term side effects of a full lymph node dissection. This is another one of the areas that I'm quite interested in. It's ovarian preservation. For years, the dogma with ovarian cancer treatment, with endometrial cancer treatment has been to take out the uterus and ovaries. The ovaries are the source of estrogen. Estrogen drives this cancer, so get the ovaries out of there. But that has real implications for young patients, premenopausal patients that are facing this disease, which is not an insubstantial number of patients. And there's evidence coming out now that in certain good prognosis patients, premenopausal, it may be very reasonable to preserve the ovaries in those patients without any decrement in overall survival. So the jury is still out on this, but I am beginning to consider this much more in my very young patients, and am getting more comfortable with this, and hopefully more data will follow to corroborate this approach. And these are just a few of the conclusions from articles out in the last year addressing the issue of ovarian preservation. So what about fertility preservation? This is also mentioned earlier. And again, data is accumulating that's making us a little bit more comfortable allowing fertility preservation for some of our younger patients who have not completed their childbearing yet. All of this data is taken with some degree of caution, as I think to date there's only just over 40 manuscripts describing this, and somewhere between 600 and 650 patients. So there's not the data to provide big, lofty statements, but certainly this is an area that research is rapidly increasing, and it is an option that can be offered in the carefully selected and counseled and motivated patient. So what about treatment after surgery? Where do we stand with that? In our low-risk patients, most of us realize or acknowledge that these patients don't need any treatment, that they will do very well after their surgery and are cured by surgery alone, with recurrence rates of only 2 to 3%. But it's the intermediate risk patients, those patients with a few risk factors that have brought the controversy in this area. For years, we've tried various recipes of radiation to treat these patients at intermediate risk. And most of these studies have demonstrated that we're able to decrease the local recurrence of the disease, the recurrence in the pelvis, but this has not translated into improvements in overall survival. And some studies have even shown it's been detrimental to overall survival, and certainly can be detrimental to long-term quality of life. As you're long after your cancer has been cured, you have the issues of radiation toxicity that you're dealing with. So this intermediate risk group is still up in the air as to the best approach. And what we tried to do is to parse this out into patients that are intermediate risk, but perhaps on the high side of intermediate risk. So now we've got a high intermediate risk category. And even with that grouping in the high risk patients, we feel like we should treat them with something after their surgery, and the question is what? And without going through each of these studies, the basic gist of these studies are, we feel like they need something. We think that radiation is probably a component of that treatment. It may be helped with chemo, but we don't know if we should give it together, if we should give chemotherapy first and then radiation, or radiation first, then chemotherapy. And the gynecologic oncology group is looking at that in this country. They've completed one trial. We're waiting for that to mature. And there's another ongoing trial. And certainly international trials are also helping us try to answer the best way to treat these high intermediate risk patients and higher risk patients after their surgery has cleared them of disease or made them where they have no gross evidence of disease. So where do we stand for metastatic and recurrent endometrial cancer? And as Dr. Bearcat was mentioning, chemotherapy has really come on as the mainstay of treatment in this group of patients. And the question is now, just as within the intermediate risk group, is there a place for multimodality treatment within this population? Is there a place for radiation added into the chemotherapy recipe? And that question is also in trials right now that we're attempting to answer. One trial that I will highlight is GOG 209 that was mentioned a little bit earlier. That was presented last year at the Society of GYN Oncology meeting. And I just want to read to you the conclusion, because I think it's telling in a couple of ways. In that study, and Dr. Bearcat had mentioned that also, this two-drug combination of Taxol and carboplatin was deemed not inferior to the three-drug combination that was the standard of care in terms of progression-free and overall survival. And overall, the toxicity profile favored the two-drug combination in this study. And the final sentence is that thus Taxol carbo, as prescribed in this study, is an acceptable backbone for further trials, in combination with targeted therapies. So the decision or the conclusion was this is not the be-all, end-all. This is where we stop. We've got our two-drug, less toxic combination. But this should be our backbone moving forward to look at targeted therapies. And this is where things are going. It's been alluded to previously, and I've discussed it with a few in the audience, that targeted therapy is really where all of our, not all of our efforts, but a significant degree of our efforts are going. And I have a number of slides that kind of go into targeted therapy, but unfortunately, I think I would usurp too much of the time if I went through all of those slides. So I'm going to try and boil it down to a couple. These are the GOG trials that have been published in the last 2 years that have incorporated targeted therapy in uterine cancer on top of the standard cytotoxic backbones or alone. Let me zip through this. So what are we talking about when we talk about targeted therapy? Well, we know that genes code proteins which often act like on and off switches within the cell. So for instance, protein A will turn on protein B, will turn on protein C, will turn off protein D. And this is carefully orchestrated and regulated within the cell like a thermostat for the perfect balance of cell proliferation when it needs to happen and cell death and decline when it needs to happen to maintain that balance. And there's usually these signaling pathways are key to allow the cell to do its function. There are key proteins that lie at each of these nodes of this pathway, the thermostats, if you will, that are really in charge of orchestrating this process. And when mutations occur in these genes, these are where we get our problems. And to highlight a couple of these. So if you think of something called what's called a proto-oncogene is really one of these thermostats that keeps things proliferating when it needs to. When this is mutating, then it becomes almost like a jammed accelerator where the cell cannot stop proliferating, cannot stop growing. That happens long enough, then you end up with cancer. And then the flip side of that, there's another type of protein called tumor suppressor genes. And if those are in charge of really putting on the brakes of the cell cycle, and if those get mutated, it's like your car has lost its brakes, and it's in this missing brake scenario, it goes careening off the ledge into this cancer profile. So you have nothing to stop the cancer from growing anymore. And so we know these tumor suppressors, these oncogenes, lie at key nodes, and if we can identify those in tumors, and we have in a number of tumors, and as was mentioned, P10 tends to be an important tumor suppressor in a lot of endometrial cancers. If we can identify those, and we know where things go awry, then we can target those or drug those. And so there's a number of drugs in the pipeline, specifically in uterine cancer, that are targeting this P10 pathway or this PI3 kinase AKT pathway that you may hear a lot about. There are a number of other pathways that are targeted or drugged in just that fashion. And so this is a much more specific way to treat cancers than the traditional cytotoxic chemotherapy, go in and kill every cell that's rapidly dividing. Much less toxicity for the patients, much more specific, personalized care, but we're just at the beginning of this, and we are just learning which drugs work, which pathways are targetable, and there's much to be done, and we need every clinical trial and every clinical trial participant possible to be able to investigate these pathways. So this is a pivotal article that was published in Nature earlier this year from the Cancer Genome Atlas, and it's helping us through molecular studies like this find pathways that we may be able to target with these specific drugs, and also how to better classify various cancers so we can divide people into better treatment groups based on the molecular profile and not necessarily how the tumor looks under the microscope, which can be limited in some cases. So I'm going to transition away from treatment, just touch on cancer survivorship, which Dr. Mattisett is going to talk about in detail. But this is really the emphasis behind learning that long after we treat our patients and long after they're finished their surgery and their chemotherapy, they're dealing with the ramifications, both psychologically of their cancer and the toxicity that our treatments have afforded them. We have turned a blind eye to that in a lot of cases, unfortunately, as we waved goodbye at your 5-year graduate from treatment visit. But we're learning just how important the survivorship process is. And this is really a patient-centered outcome that has been long overdue for us to investigate and learn more about and how we can improve our care and our partnership with our patients. And the final thing I'll mention is the study of quality in cancer care and endometrial cancer care specifically. And this is the idea that you should have some metric, or we should have some metric to give you, the patient, or give the population as to what constitutes quality cancer care. And something besides you just walking into a hospital and having to go with the "trust me, I'm a doctor" approach. How do you know your doctor knows what he's doing? What are those metrics out there? And so we're trying to define those from a patient-centered and from a specialty approach so that you know that you're getting quality care despite or no matter where you live. If you're geographically isolated, if you're socioeconomically encumbered, that you will be able to tell who I need to go to get quality cancer care and what constitutes quality cancer care. So this has been a tour de force through the research realm of endometrial cancer. It's certainly been, the last decade has been incredibly encouraging as we've moved towards minimally invasive surgery and improved outcomes with a shift towards chemotherapy. Those outcomes will continue to improve as we move towards targeted molecular therapy. The march towards better screening, prevention, and early detection, I am certain, are just a matter of a few years away. So it's a great time to be in the position I am, taking care of women with cancer, and it's certainly a great time to be involved in the research that is that's driving endometrial cancer and uterine cancer to where it needs to be, to a patient-centered experience where we cure far, far more than we are today, and to improve the long-term survivorship long after that last drop of chemotherapy has gone in. So thank you very much, and